So I work with the Clinton Health Access Initiative as the regional technical advisor for health financing, where we're leading conversations with different governments around how to make health financing reforms. But the most interesting thing is some of the countries are grappling with this question from different perspectives. So some of them are still at the point of the decisions on, are we talking about hemodialysis, peritoneal dialysis? How do we position that within the benefit packages? Then there are conversations around what investments can be made, in the overall to just improve renal care. So we're going to talk about that as well. But this session really is how do we, as practitioners in the room, engage policymakers with, that step out of the science and get into the politics of health. And we'll start with the question that was, Dr. Cheptinga asked, how do you engage, especially when you go to the transplant, to actually make sense to them and run down the numbers? So that's what I'm going to talk about. Yeah, so, but to go there, what becomes important is stepping back and looking at, there's a kidney, but the kidney is in a person, and the person exists within a system. And in this system, there are quite a lot of other players, and it could be at a country level, but most importantly, at a global level. And at a global level, there are policy discussions that people are driving that influence even at the local level what happens. So at the global level, there's a drive to achieve UHC, as envisioned by this, Sustainable Development Goals. Then, of course, one of the targets that was set was how do we move, towards improving, reducing mortality that is related to non-communicable diseases. So that's at the global level. But at the national level, there are commitments that we must, hold some of the people who make the commitments, accountable to it. So there's a UHC, and by that, I highlighted a couple of things, that there is the element of all Kenyans, there's the element of access, there's the element of quality, and finally, financial hardship. And I'm going to highlight this financial hardship because it addresses the question that Dr. Cheptinga asked: how are we covering the kidney to ensure that patients do not get into financial hardship of, in terms of accessing care? So one thing that stands out in all this is that the healthcare needs are infinite and the resources are finite. So what does that mean? That there are newer interventions. I think we've had this, Dr. Cheptinga, as you mentioned, as you're presenting today, there are quite a couple of interventions that there are options. But in this, they are changing priorities because there is a kidney, but there are other organs as well that need this kind of support. But the other point is the patient's expectations are also rising. So in terms of the needs. But, this fits into a health system, but we also have to know that, resources are finite. There's the other element that we have to keep on talking about, that our aspiration is let's have as much money as possible within the health sector, but how can we stretch that shilling to get more health? So that means what kind of thoughts can we run in our heads that can get within the existing resources to get as much as we can? Because in a health system, unlike any other financing modalities or banks, we are not in the business of saving money. We're in the business of buying lives every day. And by life, it simply means for every amount of money that we're spending, we must buy as much as we can using the interventions that do exist. So these are some of the most recent policy conversations that are going on. I think some of them as old as yesterday, some as 2 years ago. And I know, so Dr. Cheptinga, right down here is an article, an op-ed I made to the Business Daily, making the argument that you're talking about around how can NHIF move towards improving kidney in terms of kidney transplant. So I make a couple of arguments that I'm going to talk about later. But a couple of days ago, they ran their numbers and said, kidney, that dialysis now accounts is for the third in terms of their costs drivers of care. That's after major surgeries and inpatient care. So that's one of the elements that they brought out a couple of days ago. And yesterday, one of the elements that came out, they want to reduce the reimbursements they have for dialysis from, I think, the current 9,500 to 6,000, which is an interesting conversation that is tied to this, but happy to talk about that more. But I just thought I highlight this to also know that there are people talking about the kidney on the table and how we're positioning ourselves to be part of that conversation, to influence some of these bits and pieces that we're talking about, that we look at the patient, but then we step back and sit on the table and see how well to address the patient that is geared towards addressing the kidney as well. So what about, talking more about dialysis, what is the evidence out there in terms of spend? So, if you look at in most countries, in 90 countries, a study done recently showed that, despite the fact that there is a lot of focus to help, to provide care through dialysis, it only covers 29% of the population need. But if we were to cover fully using dialysis, then dialysis alone will account for from between 15 to 55% of the healthcare expenditure. So that means all the resources available for health, you'll have as much as 55% being spent on dialysis if you are to cover 100% across the 90 countries or on average. So just figure that out as we have a conversation around how do we definitively have a conversation that looks at addressing some of the issues that Dr. Cheptinga raised. So this is a quick rundown of figures that we in the article that I mentioned earlier that we ran. So we didn't factor in inflation, and there are a couple of assumptions that we made. And just to bring, quick ballpark figures without much inclusion, especially around, the tests, because we ran assumptions that there are certain tests that we need to do, especially when you're dealing with dialysis. So it will be interesting that this could actually be higher if we included issues around tests. And I'm going to talk about the other indirect costs as well. So looking at with an assumption that we're dealing with 3 weekly sessions at 9.5, that's what NHF pays, of course, ignoring the fact that they're trying to lower that. So that gives you an estimated figure, and this is a lower end without factoring in the tests, which I'm sure as a nephrologist, you know how many other tests you've got to do. Of course, with an assumption that this patient does not have an AV underlying mechanisms, because most of them are diabetics, they're hypertensive, so the other costs also that come alongside that. So we have about 7.4. Then on the kidney transplant, the figures we were working with, on the low estimates was on the public hospitals, I think having MTRH in mind, and the upper estimates looking at high, at the private hospitals on average. So, and if you look at the first year, we pumped up based on what you mentioned on induction. So there's a higher spend on induction. So coming down to that figure. So happy to talk through this in terms of what reflections are there, but it clearly shows there could be a case to make, but actually it gets more complicated because NHF pays for the surgery, but does not pay for the medication. I think that's the other point that came up. So we're going to talk about that shortly around what are the implications and how we can address the question. So those are the direct costs, but something that we need to keep in mind that they are indirect costs that the patient has to bear. Number one is travel costs. So if I'm to come to the dialysis center every 3 days, let's imagine an average of 500 shillings to and fro to the dialysis center. That's 500 per day, 3 days. That's so that per week is 1,500. If you do that times 52 weeks, then you look at the spend per annum. The other bit that we also factored in the analysis is the human capital loss. So if I have to go for dialysis every 3 days a week, it means I'm missing work. So if I'm missing work, if you use the minimum wage currently at about 15,000, so that means every week I'm missing 45,000 worth of work, but going for dialysis every week all through that period. The other point that we also factored in was the opportunity costs within the health system. By dedicating, all this number of nurses to dialysis, it means there are less nurses left to take care of other healthcare needs that the population has. So there are a couple of other considerations to look at, especially when you're making this case, that by keeping the patient, there are also other aspects that are indirect to the system and especially to the society. So what are some of the things that are happening right now in terms of how we can talk about it? So one thing that we have to be also appreciate that the coverage for the surgery is a win, is a win that we must also recognize to make sure that we keep that going and how best we shape that conversation as well. But something that we also have to keep in mind is the failure to cover the post-transplant medication itself. It's something that we should really think through and see how well to shape that conversation. Because what happens is once you don't cover it and then you lose the kidney, then it negates everything all the gains that you made earlier. And it even becomes worse because then once it fails, you have to go back to dialysis. So NHF paid for the surgery. It failed to sustain the kidney. Then, you had a failure. So it means you have to go back to dialysis, which NHF pays again, and more than what will have paid for the transplant, okay? The most interesting thing is you might actually need a second transplant, which NHF will pay for. Okay, so if you look at the cost, what it takes to actually go in and out, it accounts for quite a significant amount of money. The third one, and which becomes very important, especially an advocacy conversation, is also recognizing kidneys are a scarce resource. And so we should work towards making sure that one, we are on the table to talk about how best then can we drive availability of the organs. And secondly, how best can we shape to make sure that all policies are geared towards preserving this rare resource. And it's about someone has donated, how can we make sure that it survives? Or how can we get people understand organ donation in general and how we can shape that conversation as well. So what can Kenya Renal Association do? One of the things that we just have to also be on the forefront is what mechanisms we're establishing to capture data that enables to give enough information or longitudinally such that we're able to have these conversations around the outcomes, comparatively giving some information around outcomes, how that will be helpful, because I think we need to demonstrate a compelling evidence, even though there is, but I think a lot of people need to see more around how this could shape, in terms of improved livelihoods. And again, as I mentioned earlier, the core mandate of any health system is improved health outcomes. So whatever we do, it doesn't really matter if we do not improve health outcomes. And the second one is how do we advocate and be on the table with the MOH and the other payers. And some of these payers that I'm talking about is not only NHIF. I think we should also engage the other private payers. The reason why I'm mentioning this, because currently, if you look at the amount of the ballpark figure around what NHIF runs is almost equal to what the private insurers run. NHIF currently has, every year has in their purse about 60 billion Kenya shillings. And, the private insurers have almost the same, slightly, maybe about 50 billion in their purse. So we are talking about an amount of over 100 billion in the health sector held by the insurers, and how, as kidney specialists, we position this is really about being on the table, defining what gives more value to the patient, but at the same time trying to demonstrate them long-term gains. Because as a private insurer, one of the things that I need to see is I can front load this amount, but then in the long term, have it lowered, or I can provide good care at the beginning, then that provides savings in the coming years. Because what they're in the business of, especially as insurer, is having predictable costs and all through see a trend of that going down. But I think that's all I had for us today.